Assalamu alaikum to everyone joining us today. A good day, good evening, good afternoon, good morning to all of you from wherever you're joining us from different parts of the world. My name is Dr. Suhaila Ghuloum. I'm the Assistant Dean for the Institute for Population Health and an Associate Professor of Clinical Population Health Sciences. So thank you for joining us again for the Population Health and Wellbeing series. As you all know, the objectives of this series are to discuss contemporary and critical topics which are relevant to healthcare, medicine, population health. We also look at evidence-based practices which are germane to public health and patient care. We also describe opportunities and challenges in the evolving face of healthcare and population health. So these are just some housekeeping rules. Just to remind everybody, your cameras and microphones are turned off. You can please use the Q&A feature to type any questions or comments. You can also post them in the chat, and we will be able to review them and answer them at the end of the session. So again, this is an accredited activity, as you can see, both by ACCME and DHP at the Department of Healthcare Professions Accreditation section in Qatar also. Evaluation and certificates. So as you all may know, the post-activity evaluation, it will be available in your Cloud CME account by February 20th. You will receive an email notification once the evaluation is available in your Cloud CME account, and certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So I'm very, very excited today, for this session, and it is my honor and privilege to introduce our expert speaker for today. So as you know, the topic of our talk today is stigma and mental health, and our expert speaker today is Dr. Suhaila Ghuloum. So Dr. Ghuloum is a senior consultant psychiatrist and an associate professor at Weill Cornell Medicine-Qatar. She has national and international involvements in mental health. She was a key member in drafting the Qatar mental health strategy and mental health law. She has active teaching and administrative roles at mental health services of Hamad Medical Corporation and Weill Cornell Medicine. And she is an examiner locally and regionally. Her past roles include Chair of Mental Health Services in Qatar, Chair of Middle East Division of the Royal College of Psychiatrists, Qatar's representative to the WHO EMRO region, and the GCC Council for Mental Health, executive roles in Arab Board and Arab Federation of Psychiatrists, and zonal representative for the Middle East at World Psychiatric Association. She continues to be involved with the WHO and World Federation for Mental Health on various projects, guidelines, and position statements. Dr. Ghuloum has several research projects, publications, and presentations at regional and international conferences. So please join me in welcoming Dr. Ghuloum to the virtual podium. Dr. Ghuloum, thank you so much for doing this session today, and over to you.
Thank you very much, Dr. Chima, for inviting me, and thank you to the whole team. Everyone has been very supportive in getting through this presentation and preparing for it. So thank you all very much, and thanks to the audience for their interest in attending this topic. This is my disclosure statement. I have nothing to disclose, basically, nothing to declare, and these are the learning objectives. To me, really, as I was thinking of the learning objectives, I was trying to reflect, what is it that matters to me most when I give a talk on mental health, or when I teach students on medical students on mental health? And I think the most important aspect of it for me is if we all can reflect on our own practice, our own use of words, our own attitudes towards people with mental illness. And if we can modify that in a more positive way, if we can reflect on how much of the topic that I'm going to talk about now of stigma are we actually doing consciously or unconsciously, subconsciously, and how we can modify it, then that would be the best outcome really to expect as a learning objective. Okay, so before we start, this is the first question. What do you think, and I hope everyone would share in answering this, what do you think is the most common mental health condition in Qatar? Choose one of those four: depression, schizophrenia, anxiety, or addiction. Okay, it seems the trend is towards depression. I think we can stop the poll now. So depression is the most common, followed closely by anxiety. And you're more, well, close to the truth, because the two are quite close together, actually, in terms of the prevalence. And I'm going to show you a, if I can change my slide here. Okay, so yeah, this is a study that we had done in 2011, and it is old now, relatively. But unfortunately, there aren't many population-based studies exploring prevalence of mental illness in Qatar. This was the first one. There have been a few others, but with a more focused approach rather than exploring mental health broadly. This was a study funded by QNRF, the National Priorities Research Program, and it's already published now. And as you can see, the prevalence was very, very close between generalized anxiety disorder and major depression. So those who chose either are both correct, in fact, followed by social phobia. And we explored, in the study, we explored the most common mental health conditions, including suicide and addiction. And then we looked at comorbidities, and we looked at functioning as well. And we used the CIDI, which is a WHO instrument used for screening for mental illness at population levels. Interestingly, the way the screen goes is you don't just give it to the individuals and let them answer themselves. So it's through research assistants who have to interview those people. And then they answer the questions. And interestingly, the majority of people, when we started with a pilot, all the questions related to substance use and self-harm, the answer was no, 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 immediately. So, you know, in the end, we dropped that section of the questionnaire because we realized that we're not going to get positive answers, and we didn't explore it any further. But, you know, everybody reported no to either self-harming thoughts or substance use. Okay. In Qatar, based on that study, the prevalence of mental illness is estimated as 1 in 5, so 20% of the population. That figure had caused, when it was published, it did cause a bit of negative backlash from the media, from the public, because they thought, their understanding, I think, was that we were saying that 1 in 5 people will need to seek mental health services, and that's not true. So what the questionnaire does is explores all degrees of mental illness, from mild to severe. And people with, as you can see here in this chart, the majority fall into the mild to moderate severity. These are people who don't need to seek mental health services. They don't need to seek specialist services at all. A lot of them, especially in the mild severity degree, they can, you know, just talking to someone they trust, talking to a colleague, a friend, a family member, most of the time is enough to treat and prevent deterioration into an illness. And it's only a minority who are in the severe range who do need to seek specialized services, whether at mental health services or even in primary care. Okay. But the overall prevalence was 1 in 5. In our findings, the prevalence was highest in women, and this is expected for most of the commonest disorders. So anxiety, depression, phobia, which are the 3 most common here. Internationally, they are found to be more prevalent in women. The sample that we had researched, the significant majority were in the young adult age group, 18 to 34, sorry. And among this age group, again, the majority, like I said, were women, and the more disability, when we looked at the 30-day disability, the most disability was also among women. So they were more affected by their mental illness, okay? And when we explored comorbidities, medical comorbidities, the 3 most common were actually the commonest expected in Qatar anyway, which are ischemic heart disease, diabetes, and hypertension. And these conditions are very common in this population. Okay. A lot of more data after that started emerging, and a big part of the data came from, it was commissioned in preparation to launch the National Mental Health Strategy, Qatar's National Mental Health Strategy, which was launched 2013. It was a 5-year strategy, 2013 to 2018, okay? In preparation for that, and then subsequently preparing for the National Health Strategy, a lot of work was commissioned to explore more data in relation to mental health, and there was more attention to mental health and trying to understand it better and reflect figures better. So the findings were that among the 6 highest burdens of disease in Qatar, and I'm not talking about mental illnesses, but all disease in Qatar, 3 of the 6 highest were actually mental health conditions, and these were anxiety, depression, and substance use, okay? And 3 of the top 5 causes of disability in Qatar were mental health related. Depression as an illness, as a disease, had the highest burden of disease among all other illnesses in Qatar, okay? These figures were very significant in emphasizing to what extent mental health is affecting the population, it's affecting the health services broadly, and the, money talks figures. So the reflection on, it had reflection on the financing of mental health services, okay? The figure that I have here, 2.8%, that was estimated, again, a few years back. Honestly, I don't know what's the current expenditure on mental health, but at the time, 2.8 was an estimate, and it is actually quite low despite the demand and the needs, as we can see, and the prevalence of mental illnesses. This is significantly lower than the international average. I mean, if we take Europe, for example, it's about 4% or even more than 4% of GDP is on health expenditure, and specifically on mental health expenditure. The other finding that came up when data was being collected on mental health services was that among the Qatari population, only 25% of those who need to access mental health, so not 25% of the population, out of those who need to come to psychiatry, only 25% of them were seeking that kind of help. And among the expatriates, it was even a much lesser percentage. So only 5% of those who need to seek mental health services were seeking it. Yeah. So the gap was seen as considerable, in fact. Okay. I will go now to question number 2 before we move on to talking more about stigma and the implications of all these figures. Okay. So I will ask the audience, where do you think people would seek help first when they need it for mental health conditions? Is it a psychiatrist, general practitioner, a therapist, or traditional healer? Interesting. Okay, we can stop the poll, I think, now and look at the results. Okay, so the highest is the general practitioner. That's very interesting because that is correct elsewhere, I have to say. So in the Western world, if I can say, it is the general practitioner as the first line, as the first choice, first access to care. And this part of the world, it is actually the traditional healer who people tend to explore first before coming to psychiatry. And a lot of times people would have gone to a local healer, more than one local healer first, and then they would explore regional healers. And then usually when either their mental health deteriorates into an acute phase, or they become aggressive, or they start showing psychotic symptoms, then they seek mental health services. So the gap between the onset of symptoms and seeking help is quite prolonged in this part of the world. Okay. Okay, so in the studies that we had done, interestingly, the 80% said that they would visit a psychiatrist if they had an emotional problem, okay? But we felt that this was more to people trying to say, one of the biases that usually happen with surveys of this nature is people give the answer that they perceive as the right answer or the correct answer, rather than necessarily what they would do. Because in clinical practice, what we are seeing, and colleagues who work in mental health services can attest to that, people don't come first to a psychiatrist. We usually tend to be the last resort, in fact, but the majority do go to a healer. While in our survey, when we did the survey, just over a third said that they would visit a healer first. It's still a high percentage, but certainly more said they would seek psychiatric help. Okay, so all these figures led to this picture here. Decision makers, policymakers started listening, started paying more attention to mental health, and that was the whole desire, actually, that was the whole intention of doing all these studies. And alhamdulillah, WISH, I don't know how many of you have heard of WISH, the World Innovation Summit in Health, and that is led by Qatar Foundation. So it's an annual summit. It used to be, I think, every 2 years, now it's annual. And they started in the last few years. Every year, mental health is one of their tracks. So the way WISH works, they have different tracks covering different aspects of health. And the attendees are usually very high caliber people, experts in the field, ministers, decision makers, international figures. So it is the event for mental health policy planning, etc. And every year, mental health for health, policy and planning, and every year mental health has been very prominent in their agenda. In 2018, Michael Phelps, the Olympic swimmer, this gentleman here in the picture, he was invited as the keynote speaker. So he gave the first speech of the whole summit in the opening ceremony. That was attended by, the who's who of health planning and decision-making internationally. And he spoke of his earlier childhood experiences with attention deficit disorder, seeking therapy for ADD. And then he reflected on, as an adult, how he started developing depressive symptoms and how he eventually sought help. He didn't seek it initially, again, because of stigma, because of denial, because of a lot of factors, and then how he decided to seek help and it made a difference to him. So he described how he, after an event, although he would have won, after this hype of emotional excitement, he would dip into a depressive phase where he would feel that he doesn't want to be in the sports anymore. And at times he felt that he didn't want to live anymore, okay? That speech had a huge impact on all the audience who were there. It was amazing, really. And again, after that, more and more locally, at least in Qatar, that I can see, there has been more focus on mental health. Okay. So why do people not seek mental health services or specialized services? Why did Michael Phelps initially hesitate about seeking services and then until he decided that it was time to do so? This is mainly because of the topic of this presentation, which is stigma. Okay. Stigma has a lot of different interpretations, and if you go and explore online, you will see different definitions, but most of them, the three most common descriptives of stigma are prejudice, discrimination, and ignorance. So prejudice is where you have negative attitude towards people with mental illness. Discrimination is where people exclude those with lived experience, people with mental illness, from activities, whatever they are, social, professional, etc. And ignorance, where we don't know enough and we don't bother to know enough about mental illness. We just decide to take a negative attitude, and that's it. Okay. Other definitions have included devaluing people with mental illness, stereotyping. So we tend to, the most common stereotype is all people with mental illness are aggressive, or all people with mental illness are they're unreliable, they cannot make decisions for themselves. These kinds of stereotypes. And then labeling, all the negative labels that we hear constantly, unfortunately. Okay. So in this study, and I just felt as well preparing these presentations, I don't want people to think that I'm only reflecting papers that I have been involved with. That's not the intention at all. It's more because previously there were, 20 years ago or so, there was hardly much research exploring mental health in Qatar. And the data that I'm presenting here are the earliest presentations, the earliest research that went on about mental health, whether prevalence, public attitude, professional attitudes, etc. So this was a study exploring knowledge, attitude, and health literacy in Qatar. And it was, most of these researches are collaborative between Hamad Medical Corporation, Cornell, sometimes Qatar University, Calgary University of Nursing, and other institutions. In the study, some of the findings were expected, some of the findings were positive, actually, and encouraging, and then others were quite worrying. So it was encouraging to see that a large percentage of people said, at least reported, that they believe mental illness can be treated with psychotherapy. That was amazing, especially that at that time we had a very small psychological service. Now it has expanded. The other finding that a lot of people felt or reported that they believe mental illness can be treated with medication. So these were positive. A large percentage, almost 80%, said that people with mental illness can live in the community. That was excellent as a finding, especially comparing with regional data where the attitudes were more negative, stigma was much worse, and studies that explored public and knowledge and attitude about mental illness. The worrying aspects were the high number of respondents who believed that mental illness was a punishment from God, or that it was possession by evil spirits. And we do see that in practice very frequently. And interestingly, it doesn't necessarily have a lot to do with education. We were discussing this morning, in fact, in our rounds, clinical rounds, that we have medical colleagues, we have senior people, highly educated people who come and say, are you sure, doctor, this is not an evil eye? Are you sure this is not a possession? How do you know? How do you differentiate? So these cultural beliefs are very deeply ingrained. And being educated doesn't necessarily always make a difference. There was a lot of mixture between mental illness and mental retardation or learning disability. A large number of people believed, more than 1/3, that they can be treated with traditional healers. Worryingly, only 1/3 or less than 1/3 said that they would continue to maintain a friendship with a friend if they found out that that friend had mental illness. Okay, and more than half of the respondents said that people with mental illness broadly are dangerous. Okay. Just 1 second, I'm trying to remove, okay. Sources of information. Most people get their information about mental illness, their concept of mental illness, their understanding of it from the media. And unfortunately, we know that worldwide media has very negative portrayal of mental illness to a worrying degree. They hype up incidents. So if there was a murder, for example, caused by anything, it might be a small headline. If it was a murder by someone with mental illness, although statistically it's significantly less likely to occur, it is hyped up with bold headlines, etc. Okay. And the least source of information is healthcare staff. To us, this meant a lot because it showed that we were deficient in providing the education, the public education that we should be providing to people. Okay. So after that, there was a study led by a colleague, Dr. Kahiyan from Calgary University in Qatar. And again, it was a collaborative among different institutions. And in this study, he explored 3 levels of stigma. So internal stigma by people with lived experience, people with mental illness, and then stigma among families of people with mental illness, and then stigma among healthcare providers. Okay, so I'm going to present very briefly the findings of each. So with internalized stigma, so how patients themselves feel the stigma rather than how the public perceive them, okay? This was associated with lower levels of education, lower income, lower social support, and people who had psychotic illness had a higher degree of self-stigma, okay? And then we explored stigma among healthcare practitioners, and alhamdulillah, it was much lower than international data. So the stigma was not high, but it was still there. And it was noticeably or significantly higher among nurses than among physicians. Part of that may be explained by the fact that nurses spend more time with patients than physicians tend to do. It is associated significantly with the qualification. So clinicians who had higher degrees, had higher qualification, had a lesser stigmatizing attitude. Place of work made a difference. People who work in residential services versus acute emergency setting. And female physicians tended to have a significantly lower negative attitude towards people with mental illness than male physicians. Okay. And then the third aspect of the study was exploring stigma among families of patients with mental illness. And it was observed to be higher in married people. So patients who were married, their families had a higher degree of stigma, those from South Asian or African ethnicity, and those with a lower education. And it was associated significantly with social withdrawal. So the families, not only the patients themselves, but even their families started to withdraw more from socially, from family gatherings, etc., to maintain a distance, basically, so that people won't know that they have someone with mental illness. Okay. In all these studies, Arab women were seen to have less awareness about mental illness. I shouldn't present the slide really, but anyway, there it goes. So we had less awareness about mental illness. We believed more in possession, more in the role of traditional healers, more negative attitudes. So stigma generally among Arab women was higher than among Arab men, okay? And the biggest worry was marriage prospects. And we see that very frequently in our daily practice, people asking, if I open the file, clinical records and mental health services, would it be accessible to others? Would I be known to have a mental illness? Would it affect my chances at being married, especially with premarital screening? And I'll talk a little bit about that at the end, inshallah. Okay, now this was a qualitative study exploring stigma towards mental disorders in Qatar. Okay, and what they did is they interviewed people with mental illness and they interviewed families as well, but it wasn't a quantitative, so it wasn't a questionnaire that was given, it was more interviews and qualitative type study. Okay, and in the study, they explored two aspects of stigma: implicit stigma, also referred to as stigma by proxy, and then explicit. So what stigma by proxy means is emphasized in this statement. This is, so I'm just controlling my, oops, okay. This is a statement by one of the patients that they had interviewed in this study. And what she said was that she was with a group talking among friends about one of the friends who had depression. And then afterwards, one of them approached her and said, oh, how heavy that story, that girl was so sick, I did not realize she was Coco. So again, it's about labeling these expressions that people use. And although it wasn't targeting her, but this is stigma by proxy, she reflected, okay, if this is the attitude towards that friend, then if I informed my friend that I have depression as well, she will also think of me as Coco, and therefore I'm not going to say anything. And that results usually in people with mental illness minimizing their social circle or being guarded among their social circle. So it does affect their socializing and their quality of life generally. Okay. I'm going to move on to the third question now. Can we have the poll? So basically, it's interesting to know how many of the audience think that medication, antidepressants specifically, can cause addiction or dependence. Very close between true and false. Okay, we can stop the poll. So 62% say true, 38% say false. Okay, I hope none of those working in mental health services said true, because that would get me really concerned. Okay. Again, this is a very common misconception. It's a very common question that we get asked when we talk to patients about medication, those who do need medication. Will I be addicted? Will I stop? Can I stop these medications? Will it affect me in the long run? Will it affect my brain? Will it make me more mentally ill than I am at the moment, etc.? Then they go, and even although we assure them that that is not true, so the correct answer is definitely, absolutely false. None of the antidepressants causes addiction or tolerance or dependence. But people go and explore online, and then they come back to us telling us, well, I stopped the medication because I worried, because I read online that it can cause addiction, and this person or that person took it and they weren't able to stop. And none of that is true. The only ones that are addictive, or the main ones that are addictive in mental health practice, are benzodiazepines, and they're not used for depression. Okay. So with that, there was a study done by colleagues at Qatar University to explore the perspective of university students in Qatar about stigma and their attitude towards people with mental illness. Okay, interestingly, the majority thought that medication does cause addiction. So again, this is a very, very common misperception, regardless of educational level. Half of them thought that it was a punishment from God. The majority thought that people with mental illness are dangerous and that they cannot have regular jobs. Okay, so all these deeply ingrained stigmatizing beliefs and misconceptions about mental illness. Okay. This is one of these statements, again, from a qualitative study. A patient who says every illness is hard to deal with, which is true. The difference is when you're sick, people tend to care for you and they give you a break. But when you have a mental illness, they hide you, they judge you, and they treat you differently. I won't allow it. I won't be stigmatized because I'm sick. So this is someone who was actually going out and telling her friends and telling everyone in her family that she is seeing a psychiatrist and a psychologist, and she is seeking therapy. Okay. So in the slide, this code that I showed you, you can see the website here. It's called Isma'ni, which basically means hear me out or listen to me. And this is a website that was created by the research team who did a qualitative, actually, no, this was a different research team, but there was another qualitative study or a market study commissioned by the mental health team at the Ministry of Public Health. The guiding statement was driven from the Qatar National Mental Health Strategy to implement effective strategies for mental health promotion. Okay. And this qualitative study, what they did is they approached a market research, they approached different groups of people divided in 3 segments. Some of them were people with lived experience, so those with mental illness. Others are people who know someone with mental illness, so either a friend or a family member with mental illness, and then individuals who had no concept of mental illness. They didn't know anyone personally with mental health issues. Okay, and the target was Arabic-speaking people because it was qualitative and all the researchers were Arab, so it was in Arabic only. And these were the key themes that emerged: understanding of mental health, attitudes, awareness, and effective communication messages. So what people wanted in terms of raising awareness about mental illness. Okay. So among the respondents, most of them, this is what they understood as being mentally healthy. So being happy, being normal, the concept of normality, that's equal to mental health. being happy, having positive attitudes, taking care of things, taking care of others, social, and being balanced. These are the words that they described referring to mental health. And one of them, interestingly, said being mentally present as being healthy. Okay. Stigma, they in that study, in that market research, stigma was reported as being the main reason why why people will not seek help. And that emerged in the descriptives that those respondents used in describing people with mental illness. So all of this list, that those with mental illness shouldn't marry, they're dangerous, they're jinxed, they're cursed, they should be hidden. And even that they're contagious, that mental illness, almost like an infectious disease, it can be contagious. All these misconceptions of mental illness. This is a Qatari female who, she's from S2, that is segment 2. So she didn't have mental illness herself, but she knew someone with mental illness. And her statement was quite interesting. That's why, I wanted to reflect it here. And it's very true. So she says, if the place is well cultured, you would see that there's more awareness and people are better. So the more cultured a society is, the better aware they are of mental health, and the less prejudiced and the less stigmatizing they are about mental health. Okay. In response to why they wouldn't openly discuss their mental health issues, and the answers were because mental health is not common in Qatar. Well, we know that it's 1 in 5, so that's pretty common. But the perception was that it's not common because nobody would disclose it, nobody would talk openly about it, that people with mental illness are out of their mind. They worry about saying it to a friend in case someone else might overhear them. They worry about disclosing it even to their parents, for example. They worry that their siblings might overhear them talking about it, and therefore they just won't, and they would feel ashamed to openly disclose their mental health issues. Okay. Another statement from an Arab female who had mental illness herself, saying that we would be lying if we had good mental health all the time. And of course, nobody can be happy all the time. We all go through episodes of not feeling very happy, not necessarily being mentally ill, but not being perfectly mentally healthy either. Okay. And because of all these stigmatizing attitudes, and because of such a high level of stigma generally, not only in Qatar, but in this part of the world. Sorry, the poll is popping up for me again. I'll just delete it. Okay. People are seeking help quite late. Sorry, Raji, the poll question keeps popping up for me. I don't know why.
Not to worry, I'll take care of it.
All right, thank you. So people delay seeking help. They, like I was saying earlier, the gap between the onset of mental ill health or symptoms and seeking professional help is quite long, and it's usually a good number of years. We don't have exact figures. We haven't studied that, unfortunately. But based on clinical experience, I would say the minimum is 3 to 4 years, and it can be as high as 7, 8 years at times before people seek help. Most of the time, bear in mind the onset of mental illness, of the commonest mental disorders, tends to be in teenage years, late adolescence, early adulthood, and families and friends, etc. Patients themselves, they may think that this is personality change associated with adolescence, and therefore they don't consider it as a mental health issue, and they don't seek help. And we see that regularly in our inpatient services, actually, when they require admission eventually. Okay. Having such a stigmatized attitude, not only among the public, but also among policymakers, decision makers, delays the establishment of adequate services. Okay. I'm not going to say anything beyond, just those of you who have seen the psychiatry hospital and have seen, I'm not going to name other facilities, but any other facility under HMC, they can understand what I'm referring to. There's a huge difference in standard between the facilities. Okay. It results in isolation, results in low self-esteem, people with mental illness, people with lived experience being harassed. It affects their employment, so they cannot function as well. And even if they can, function, they are concerned about their employers finding out about their mental illness. And a lot of times when they need a sick leave for a period of time, they prefer to take it from their annual leave or unpaid leave rather than have a sick note from mental health services. Yeah, because they don't trust the confidentiality of their health condition being disclosed. Marital prospects, I've alluded to that earlier. This is a very, very common concern. People worry about information about their mental health being revealed. And I feel it's very important to say that nowadays it's even a larger worry, because with the premarital screening, even if the worry is that if someone had an episode of anxiety, let's say, years ago, they worry that this may come up in their premarital screen. And to what extent will that be disclosed to the potential partner? And all the stigma that would be associated with it, the invasion of personal information and privacy that will result of it, and to what extent that will affect the going ahead with the marriage. Yeah, bearing in mind that marriages here are all, well, the majority are arranged marriages. So people don't know each other and they rely on a family arranging it. Yeah. And interestingly, there is talk lately, actually, for the past couple of years, about premarital screening for mental illness. And you can imagine to what extent that will result in problems. It's not the focus of this presentation. I just wanted to emphasize it, that just to reflect how strongly I feel against it, basically. Okay. And all the surveys that have been done about either stigma or knowledge of mental illness, attitudes, etc. In all of these studies, we were asking, or other researchers were asking people, respondents, what kind of messages, where would they like, what kind of help would they like to see being available for them? And the majority, the most common, was they want this kind of help to be anonymous. So they don't want anything that says psychiatry or mental health, even though it's health, but the word mental, they didn't want it to be reflected anywhere. They wanted more guarantees of confidentiality, receiving expert help, not only psychiatrists, but the whole multidisciplinary care, psychologists, occupational therapists, etc., social workers, everyone. They preferred online therapy rather than in person. And we have seen that actually now with COVID, because all care was shifted to either over the phone or online. More people are seeking help. In fact, they feel more comfortable with it than coming in person. They don't want any signages, so they don't want anything that says psychiatry hospital or mental health services. And they all prefer, the majority prefer religious figures to be involved in their care. Okay. So I'll go quickly in the remaining few minutes over some of the recommendations. Some of these are based on personal experience or personal views, maybe. Others are based on research findings, recommendations from the respondents and all the researches that were done locally. And some of them are international findings, in fact. Okay. So having a campaign that, there's been a lot of efforts locally in Qatar to raise awareness of mental health and combat stigma. But these changes don't happen overnight. And personally, the evidence says that having a campaign that goes on for a day or two, or even a week, for example, around mental health, International Mental Health Day, that does not affect, it may produce a positive outcome for a short term afterwards, but then it dies out and people go back to their pre-campaign levels of stigma and knowledge, perception, etc. So there needs to be a phased community awareness activity. It needs to be ongoing, lesser intensity, but more persistent to genuinely impact the attitudes and beliefs. Okay? Technology needs to be used more intensively, especially lately nowadays, where most young people, adolescents, early adults, they use technology very heavily and they rely on it. Careful selective of messages, the wordings that we use when we refer to people with mental illness. There was a debate a while back about using comedy and should we approach it from a comedy perspective. It can work, but we have to be very cautious how this comedy is done. It needs to be tasteful and avoid insulting unintentionally people with mental illness. Using colloquial language, so rather than using in Arabic, there's a lot of different dialects, so to make it more approachable to the target population, so you're not using the formal Arabic that people may not affiliate with. Okay? More community engagement in activities, engaging healers. I don't think we can succeed in combating or fighting stigma or minimizing it if we don't involve the healers. People believe in them very strongly, and a lot of them we need to engage them, we need to educate them and engage them in raising public awareness. Psychiatry spokespersons, or even, so there was a talk a few years back about having spokespeople from psychiatry who are the ones who would go on the media to talk about mental health issues on TV and newspapers, etc., and social media. Yeah, but more importantly than psychiatry spokespersons, I think we need people with lived experience to talk about their experience, and this is very difficult currently, and I don't see that happening in the near future in Qatar or in this region broadly. Explore more, using cinema, radio, games even for advertising and talking about mental health, educating not only patients and their families and the public, but even healthcare providers, like in these sorts of sessions. Doing more research, collecting more data, more figures. We have seen firsthand how figures have made a difference to the decision makers and made them listen and pay more attention to mental health. Facilities, I have deliberately bolded, written it in italics, underlined, read, any other thing I could do to emphasize the importance of having a facility. We could all be talking for ages about the importance of mental health and fighting stigma against mental health, but then people come and see an old facility that is not purpose-built, that is not conducive to a positive mental health, it doesn't have the right ambience, the right environment, and that beats it all, So we need to have the right facility, and a lot of times just having the right setting can affect, it's known to have a positive impact on perception and on attitudes. Okay. This was a research done by colleagues at Qatar University, and in their recommendations, they emphasized the importance of engaging the religious teachings and not disregarding them, that we need to improve mental health literacy, but without making misleading associations, without undermining the positive messages of religious teachings. Okay. And again, they talk about integrating families and religious figures. Okay. This is an example of what I was talking about earlier, that people with lived experience, people with mental illness, they are the ones who would make the biggest change if they started talking more openly about their experience. And here we have Lady Gaga, who spoke openly about her personal experience with mental illness. She has a huge number of followers, and when someone like her talks positively about an issue, her followers would think the same of it as well, especially that they're young people who are very adaptive in terms of their ideologies and beliefs. Dwayne Johnson spoke also for mental. There's a lot actually in the West who have a lot of actors, a lot of celebrities who spoke about mental illness. And in the UK, a few years back, Stephen Fry, who's a very well-known TV figure in the UK, he spoke about his experience with bipolar disorder. And interestingly, colleagues in the UK were saying that after that, they had, in a way it was positive, but on the other hand, it was a bit, with caution, that a lot of people were going to them with symptoms, inquiring whether they had bipolar disorder, and people were more accepting, and they sought mental health services more openly after he spoke openly of it. Okay. In the Arab world, there's very few, but we started seeing more Arab celebrities talking about their personal experience. These are Arabic singers and actress. One of them is an actress who spoke about their personal experience with depression. And again, that had an impact in their countries, at least, if not regionally, on acceptance of mental health. This is a website, an Instagram account. So on Instagram, there's quite a few, again, talking about using social media. This account has 4.7 million followers, and it talks about, people's experiences with their own mental health. It has, every day they send a few positive messages about support, etc., for people with mental health conditions. There's an Instagram project here for you. Again, it has a lot of followers, and there is evidence that these things do work. This is from Qatar locally. Your Mind Matters, صحتك النفسية. Again, it was a campaign done around World Mental Health Day to raise public awareness about mental health, and with the focus, similar to the UK campaign of "It's okay not to be okay." That was the main message of it. This is just to reflect evidence that these public awareness activities, these campaigns do work. They do impact stigma. They do have a positive impact on it. And I will leave you with this final slide, again, from this website, Isma'ni, that has quotes from people with mental illness talking about stigma and how it needs to change. And have you ever heard of a person having a cold and feeling stigma for getting a cold? So why should we get stigma for having mental illness? It's an illness just like any other medical problem. Thank you very much.
So thank you so much for doing this session. I've certainly learned a lot.
Thank you for inviting me.
No, thank you for being here and sharing all your great advice with us. And inshallah, we hope, to see it moving towards a better pathway. Because of course, mental illness is very important for our health, and we are seeing an increasing rise in its prevalence. So inshallah, I hope all of us as healthcare professionals can certainly, play a role in reducing its incidence. So thank you again.
Inshallah. Thank you all very much. Thank you.
Thank you for joining us today. And we have a great lineup of speakers for the next couple of months. And inshallah, I hope to see all of you again there. Thank you again. Bye-bye.